My name is Linda Robinson. I'm Chief Executive of AgeNI. I've worked in services for older people for over 25 years now. I have a particular interest in dementia, and our organisation is a regional organisation supporting and listening to the voice of older people.
Hi, I'm Judith Cross, and I'm the strategic policy advisor with a specific focus on health and social care within AgeNI.
Thank you.
Okay, thank you very much for this opportunity to give evidence today. And we're obviously very concerned on the impact of emergency care departments on older people. And we believe certainly there's a change needed in health and social care in that delivery. We support a view that there's a whole systems approach to this, and I know the Chair mentioned a little bit earlier in his opening comments that emergency department is part of a continuum, and they all need to work in a way that means that it works for the older person when they come to the door of any of those services. And in particular, if transforming your care is really to do the deal that it's supposed to do, then this has to work for all older people. We feel that shift left hasn't really occurred and hasn't happened, and we would view that there is an immediate need to invest to save in the provision of social care, to realise and also to release savings in the future. We've written extensively on how low-level preventative services can reduce attendances at emergency departments by, in effect, in around 29%. And for every £1 spent, the hospitals could save £1.20 in emergency beds. How we care for older people in emergency care settings and the environment of a busy emergency department may not be conducive to the delivery of good quality care delivered with dignity for older people. Whilst AgeNI has no delivery role in emergency care, we certainly hear of the consequences of when it goes wrong. So we've had a number of older people who have come to us with their experiences of 12-hour waits in accident and emergency departments, the impact on older carers looking after someone with dementia on a ward, and some of those I'll cover a little bit later. The charity provides a range of services, as I've mentioned earlier, across Northern Ireland, and we have access to over sort of 340,000 contacts with older people, and so we do pick up whenever things go wrong, and hopefully we can lobby and campaign on that voice. And that's right across Northern Ireland, both in terms of services for home care, services for daycare, and services for people who need advice and information. And we're there in time of crisis to make sure that there is a voice to support those older people. AgeNI has a firm belief that older people of all health and social care settings must be meaningfully engaged in all aspects of their care and support. However, the regulation and inspection regime all too often ensures that participation isn't maybe as fully as it should be. The Northern Ireland Human Rights Commission has also noted in the report in defence of dignity and that in areas of participation and autonomy, residents are not given adequate opportunity to be involved in decision making that impacts on them. And we also hear from that within the emergency departments as well. AgeNI recognises that there's an increasing requirement for engagement of older people in the development of policy of services concerning them, as there is a real risk that older people in health and social care settings will be significantly impacted by policies but absent from the decision making in that process. Again, nowhere is it more evident than in the health and social care setting. However, consultation and participation under Section 75 of the Northern Ireland Act tends to be almost a tick box tokenism aspect. If statutory bodies are serious about involving older people in services and design and delivery, they must talk to them. Organisations must be committed to believing in engagement and taking on board what older people are telling them. That should be a willingness and a motivation to take changes as a result of listening to older people. Attitudes and beliefs of decision makers and preconceived opinions on the possibilities of older people to meaningfully engage and the perception of older people are dependent and vulnerable, are real barriers to ensuring meaningful engagement when it's required. Some practical barriers can be the lack of options for including older people who have hearing loss, sight loss, confined to bed, or older people from minority communities. Again, aspects of which you will hear within your emergency departments. There has been much work on engaging and ensuring the participation of children and young people, but unfortunately we would feel that hasn't been extended with the same focus to vulnerable older people. Participation is a fundamental human right, and older people have a right to participate in all areas of lives, and this includes all matters that affect. Participation rights are also important in realising other rights to information, decision-making and fulfilment. In situations where older people are denied that participation rights, other rights may be weakened. Equally, older people who are living in poverty, fuel poverty, poor housing, living with dementia, or who face abuse, will face major obstacles in the exercising of their participation rights. It is incumbent on all areas of government to ensure that older people participate and engage, particularly those within our vulnerable communities. AGNI urges this committee to engage in a process of direct engagement with older people and listening to the experiences that they have done over this last number of weeks. AGNI has spent a number of years developing a peer facilitator approach to ensure that the direct voice of older people influences our work. Approximately 60 older people have joined teams of facilitators, and we've completed bespoke training which has enabled those older people to participate fully in gaining the voice of hard-to-reach voices, both in terms of residential care and recently the residential closures, and also more recently in having a voice within the development of standards in nursing care for those people actually being able to participate who are in nursing homes themselves. And the Department are reviewing that legislation as we speak. The evidence...
We're in your last minute, if that's okay.
Thank you, Chair. The evidence on changing demographics would push us towards a situation where we really do want to ensure that the voice of older people, particularly those more difficult, is heard. Our examples would be where we have had in Meadowbank a situation where we've had older people transferred back from an accident and emergency department without assistance by taxi. We've also had situations where out-of-hours doctors would perhaps not view the client but encourage them straight to go to accident and emergency, where they then will be sitting in delayed waits for up to 12 hours, trolley waits, corridors, which most of the more difficult impact has also been on those older carers. We therefore have a situation where we have people with dementia who any long periods of time increase agitation and increased distress, not ability therefore to have their medication in time, and also more importantly their hydration needs met. Real concerns in terms of residents where we've experienced that in recent years, and also the impacts that has had on older carers who have then become unwell in terms of that caring role. So the issues of returning home from accident and emergencies is just as important for us to flag up at this committee as it is of actually the admission processes and then the length of time waiting for beds and for obviously health improvements. In conclusions, everyone has a right to participate in decision making that affects human rights. We fully support this Commission in finding those hard to reach voices, and for us it's certainly the issue of older people, particularly that over 85 age group, and in particular for us those older people with dementia and their carers. Thank you.
Linda, thank you very much. I'll kick off with I think 2 or 3 questions, and I'll ask you to my colleague Marion. You started by talking about the importance, I think, of transforming your care and looking at social care as well as health care. And if I picked you up right, you talked about the importance of some of the low level but important things that could be done that would release some of the pressures on the emergency department. I wonder if you'd say a little bit more about what kind of things you actually have in mind in practice that you think will, if you like, ease and support emergency departments.
Yeah. I think for us it's looking at that as a continuum of services and a menu of services, and for us that low level support is care at home, whereby we have more regular contact for older people to reduce social isolation, befriending, support in the house. What older people are saying to us is that low-level needs of shopping, making sure someone are getting a meal, make sure that there's a call, a daily, even as a telephone call, but it's about stopping as early as possible the impact of maybe an illness progressing to a stage whereby that individual is then admitted to emergency departments. So it's the contact is one of the key aspects of those little bits of help, that someone checking out and talking to them. In our daycare services, we have a daily check on those individuals and catching on early if perhaps they need something to stop an infection earlier than perhaps it would have been had it went unnoticed. So it's really that low-level support, that contact, reduce social isolation, and have services at the earliest opportunity to make an impact.
Sorry, is it? I mean, I'll come in here. One of the difficulties we have within AGNI is that we know that trusts are only meeting a critical need in terms of social care. So as Lindis says, had low sort of level preventative care hasn't actually been met. We had a service, and 2 hours of his time cost £80, and he went out to people's homes. He made actually sure that the lights were okay, that the rugs were lifted off the floor, there were handrails put in. And we know that if somebody trips and has a fall, which is extremely common, especially for the older, the cost of a hip replacement is £25,000, and that doesn't take on the ongoing care needs. It also doesn't take. It also doesn't take the impact on the older person. So we don't understand how the Department of Health, we have called on them consistently to produce a regional preventative strategy for Northern Ireland, because without that you're going to have older people showing up in A and E, and it's something that nobody wants.
Okay, thank you. Second area I want to ask about is something we've heard about in a number of our public hearings, and that's the transfer of people from nursing homes and sometimes residential care homes to emergency departments at a time of near death, and the question of whether it's appropriate to do that, or actually whether near care and a near death situation should be provided actually at the nursing home and the care home, both for the individual and family members, etc. And I know that you've done a lot of work around standards of care in nursing homes, etc. And I wonder if you'd say anything about whether you have looked at that issue, and if so, what conclusions you might have drawn from that.
It's a very topical issue at the moment, because I'm part of a long-term and end-of-life care group that's going on up at the department. And one of the key things that, and certainly in our experiences in Meadowbank, has been that at a time when families and that individual needs the surroundings of what they know, they're being transferred out into a cold emergency department. And I think a lot of that has to do with getting a good understanding locally on the ground that services delivered within that person's own home, or whether that be an individual home or within a care home, needs really to be almost emphasised and set out in the advanced care plans, that we want people to live well, and if I may say, die well, that is dying with those around them, that it's not strangers. And to do that, that needs a lot of training and an investment in those settings. For a number of people, it's perhaps easier through the services we have at the moment for people having end-of-life care at hospice or, planned in their own home. It's a very difficult and different surroundings when it goes into residential or nursing homes, because again there has been occasions, and we've met with that, where perhaps it's been a GP who's not familiar with the case, but it comes out through the out-of-hours system, and it's been a case of transfer on out to emergency departments. So I would hope that the work that's going on at the department, which will see hopefully a change in how we care for people to die at home or in homes, will be the answer to that question as well.
Okay, thank you. And then one final question from me, and a very short one. In your evidence to the Commission, one of the issues you raised was the need for disaggregated data in terms of older people going to the emergency department. And I wonder if you'd say a little bit more about what is the data you think should be kept, and if it was kept, what it would bring to the table and how it would help. So again, a little bit more just on what it is you think is currently missing and what can be done with that.
This is something that goes across the board. It isn't just the data for emergency care. Organisations like the Nuffield Trust have also made comment on the dearth of actually good quality data. And I suppose our argument is, if you don't know who your population are, if you don't know what their needs are, how on earth can you plan then for services? When I tried to find information on the number of older people that have presented at A&E, the department couldn't tell me. They said they don't keep that. And I'm saying, well then, how do you know? I mean, how can you plan for services again if you don't know who your actual population are? And as I say, this goes across the whole health and social care agenda. We just don't have the data.
And when we say don't have it, it's age-specific data you're looking for. It's gender as well. What are the things you're looking for?
Well, I suppose for us it is age, but again we know that over 60% of those over 85 are female, so therefore there are impacts there. We know that as you get older, the levels of a disability sort of rise. So again, information on that. Again, there is very little information on holder SEB, very little information on holder BME populations. How many holder BME people are in nursing homes? Again, are their needs being met? Are their dietary, spiritual requirements being met? So if we don't have that, sure. How do we know? I suppose it's a basic say.
Okay, thank you. Marion?
Hello. I have only one question, and you've touched on it in your presentation, in terms of participation and people's rights to participate. And I'm wondering, could you outline how Age Northern Ireland has been involved in planning for either community care services, minor injuries units, or emergency care?
We haven't been involved in the planning for the emergency departments. We have been involved in terms of some of the health and social care changes that came through from Transforming Your Care. And more recently, we've been involved through the peer facilitator model, which we feel is a better model to make sure that the voice of older people has been heard. More recently, as noted, that was with regards to residential home closures, and the second more recent one was the nursing home standards. And what we think the model of best practice is that older people by experts are more likely in a peer-to-peer mode to get that voice and to get that information, to get that experience from those individuals, those older people who are not used to giving their voice and having their voice heard. So we find it to be a much more beneficial resource, so that we can take those experiences and make sure that those are put in the pot whenever they're developing and planning services. The resultant of for example, the nursing standards one is that information around quality and around dignity will be reflected in those revised standards, and it's more meaningful, and it's not just a tick box exercise, it's meaningful engagement, and we've found that as a model of best practice is working for our organisation as well.
And how can you get that embedded into how government and organisations work with you in the future?
It's a very slow process. We've started it, and what we're hoping is that because both of them are rooted within the department, within government, that it's almost like a little acorn is going to start to now, in every piece of work that we do, that comes as part of, when you speak to AGNI, you speak to people who have had that experience, or who are able to share the experience of those less able to speak for themselves. But it's a very slow process. I think it's still very new to people in terms of timing of, for example, the time needed to do that and to do it right, particularly if you're dealing with someone with dementia. It's not a 15-minute telephone call. It's about building up a relationship and using maybe other means to get those experiences through. And that's a very slow process, but I think taking time to do it is the right thing to do, because it will produce evidence that provides you with the mandate to change what you need to change.
Paul.
Thank you very much. And I have a question which is following up very much on Marion's. If I could take it, if I could add to Marion's question, please. And it's about the commissioning process. And as I understand it, there's the commissioning board, and there are the local commissioning groups. There are, of course, the boards of the 5 trusts, and they have executive directors, and they also have 6 non-executive directors. So could you, elaborating on your response to Marion, could you briefly elaborate a little bit on the opportunities provided for you to influence those commissioning processes?
Mm-hmm. Well, for us at the moment, the influencing processes has been our engagements with trusts and the LCGs and the board, primarily as an organisation, as AGNI, making a representation about particular policy directions, or in terms of practice that we hear about through our network of older people. In terms of the peer facilitators and using it by expert and by experience, that's a model that really has got legs to grow. We certainly have used it at the board, we have certainly used it at the trusts, but we have not had the opportunity to move more freely within the LCGs in terms of that model, but we think it's a model that works. In particular, and certainly for us, it makes particular necessary in terms of that over 85 with dementia group. And that's and that's where we want to start to move more freely amongst all those groups in terms of the services that they're commissioning or they're designing. For me, it's getting in even before we get to the commission. It's about the designing and the planning, and getting that right before we move to a system that we know it will work. So let's put resources to it. And the design for me is critical. We talk a lot now about age-friendly. And we talk a lot now about dementia-friendly. The two should be the same, because we have older people with dementia, but they're an older person first and foremost. It's that mindset and that ethos we want to really get as a cultural shift within lots of departments, both health and others.
So I have the impression that there's some openness and reaching out from different trust boards to hear your views and benefit from your experience and expertise. Is it fair to say that that is a bit uneven across the boards? So are some, you needn't name names if you don't wish to, but are there some boards that are sort of more open to your views and more inclusive than other boards, or is it fairly standard practice across the 5?
Yeah, I in my experiences, the practice in terms of involvement would be fairly even. There are some that maybe have a bit more of an edge, but not anything that there's one trust out in front of another. Right. I think we've certainly had the sea change of people actively now trying to do the best with what is in front of them. I think that a lot of it has been, there's so much resources taken out of health that we've got to a bit now where there's a very, very real struggle. And I think that impacts then on how things are delivered on the ground, and we would certainly see that. Where that differs in trusts, I think, is where there's perhaps a different emphasis on what the service delivery model is. And that, even though we have a very small Northern Ireland, there is practice across 5 trusts that is very different. We will also see how policy is implemented very differently. When we had the old model of 16 trusts, we used to say, everything's doing, certainly there surely be one model, one uniformed approach. We reduced it down to 5, and, my experiences would be that there's still a lot of differences in how things are delivered. Right. And I think, sorry, just on one final point, I think we also have to recognise in that with some trusts there is an element of that rural, and for example the Western Trust, very different to the Belfast Trust, and I don't know maybe necessarily if that's recognised as well as it should be.
Right. So as I understand it, there are PPI forums in some trusts, or perhaps in all trusts. Do you engage? Do you engage with the PPI forums, or is that
some of our local networks of older people would do it very locally on the ground, so that there's representation, and that will very much link into operational issues and details about what is happening locally and the impact locally of services. I know the whole issue around hospital closures in Omagh was a very, very raw to our groups that are in Omagh and to our own home here in Omagh, but obviously a very different response whenever you had our Belfast groups who are very well used to having perhaps 4 or 5 hospitals on their doorstep. So it's about local older people having their own needs met, and that's where we use our networks, because it's very important that the local voice is heard.
So the picture that I'm getting is that, to the great credit of everybody involved, there's some reaching out by trust boards to benefit from your experience and expertise. So that's relatively clear. Can I just put something else to you? And I'm really interested in what your view is. I'm not saying it's a great idea or a bad idea. I'm just trying to figure it out. But in addition to reaching out, another way of securing sort of public engagement is by ensuring that the trust boards and the local commissioning boards, their composition is reflective of a diverse society. So that's another way of reinforcing what you're talking about. So if one went down that road, then you'd be looking at the boards of trusts and you'd be asking, well, are older people represented there? Are ethnic minorities represented there? When I say represented, I don't mean that they're formally there as a delegate. I just mean, are LGBT people there? Ethnic minorities, whatever. So that's another way that could be pursued in order to ensure that the governing bodies are reflective of a culturally rich and diverse society. So there's the reaching out, which you've talked about, and that seems to be done. Then another way is ensuring that the governance bodies themselves have these individuals from different segments of society. Could you, if I've made myself sufficiently clear, what do you think about that model of securing the voices of the elderly and other groups in the commissioning process and delivery process of healthcare?
Yeah, I think certainly from the model of governance, a lot of the time now it's very much put into governance and risk, and I think it would be important, and the model of it, how it actually looks, would be quite interesting, because you could have quite a big group and which you wouldn't want. But I certainly believe that there are mechanisms by which you can make sure that the views of those particular groups, and in particular if there's something on the agenda that is of importance to that particular group, that their views, access to speaking rights, or if support is needed by way of other people speaking on the person's behalf, are engaged in the decision making as well. So it's okay to come along and to take on board information from a particular group, but I think what would be more important is to make sure that is then impacted on within the decision making of that trust board. And I'm not sure whether that's quite right there yet. I'm not, wouldn't be sure.
But frankly speaking, would you wish it to be? I mean, do you think that would be progress? And I don't mean that there would be. Let's not take the elderly for now.
Yeah.
Let's say people with disabilities.
Yeah.
Let's say there's someone with a disability who's on the board of a trust as a non-executive director. I don't mean that their only job would be to talk about the interests of those with disabilities. I mean, they'd be there to try and convey their views generally, but they would have that experience.
Yes.
And they would bring that rich experience to the board. So is that the way to go, or am I barking up the wrong tree?
Well, I mean, I think I stand your question, and I suppose, is this the main streaming versus a positive action sort of a debate? And I know in terms of the non-executive directors, that is done by the public appointment process. And I know from the from research that has been done on that, an awful lot of people, it's called the stock and flow. There's all these people that have public appointment experience, and they just move from one public appointment to the next, and it's very hard to actually get up into that, those big circular things. But I suppose for us in AGNI, it's okay. I mean, we all have an age. We all have an age, and it's the same. It's a similar argument in terms of a gender. You can have a lot of women there, but nobody aware of the genderised debates. And for us in AGNI, that understanding and awareness of what it is to be older, and what ageism looks like. And I would imagine if you looked at the non-executive directors of the boards, and I'm sorry if there are any of them here, but I'd say they're all quite old or older. So just because you're old actually doesn't mean you have an understanding of what it is to be old, especially when in a health and social care setting. And the same for somebody who is disabled is actually, well, you need to have that actually social construction mindset to be able to argue constructively on behalf, but if you're there as an older representative. And I'm sort of on I don't know whether it's a good idea to have older people specifically there as older people, and how, if they aren't aware of what the sort of issues are, and I'm not sure if you can have that one lassie voice. But I'm not sure if I've answered your question, but it's just a debate that I suppose we always have within sort of Northern Ireland anyway.
Thank you both. And finally, I'm really gratified that in your really interesting document about the vision to action transforming your care, there's several references to human rights and equality, so thank you for that.
Oh, very good, thank you. That means something come from yourself.
So do you have any recommendations on what could be done in order to make it easier to roll out this human rights approach to social care and health care? Are there particular obstacles to rolling this out? And if there are obstacles, then do you have any thoughts on what might be done to enhance this process of integrating human rights and equality throughout health and social care?
I suppose it begins with a dialogue, and it begins with an understanding of what human rights and equality are. And within Northern Ireland, both are very contested concepts. And I suppose it's how you move that dialogue along. And I suppose there is a role for the Commission here, because they do have a sort of role in ensuring people understand what human sort of rights are. And again, we've had examples of the Equality and Human Rights Commission in GB, who have done a lot of actually reports into actually social care. and they have actually documented the terrible sort of abuses in home care in England. And I know the Commission's own actually report in defence of a dignity was very well also actually documented a sort of abuse and so forth. So I suppose it's just that constant dialogue and keeping it high on the agenda. One of the things within AGNI we find that nobody really wants to talk about actually social care. We're all happy to stand outside our hospital with our placard saying "Don't close me," but we're not outside Mrs. Smith's store, who's lost her 4 hours of care. I suppose it's how to keep it up on the agenda. One of the main planks, there are a couple of main planks that AGNI has called for in taking forward its work on social care. And one is the review of social care legislation within Northern Ireland. Some of our legislation in terms of social care dates back to 1948. And we have called on the department as they roll out the review of social care that we have a new model of social care legislation that is based on rights. So that's the first thing. The second thing is Northern Ireland is the only place in these islands, north, south, east or west, that doesn't have goods facilities and services in terms of age is the only ground where it's legal. It's still legal to discriminate. So AGNI, again, one of our other planks is we have called for the Department of Health to undertake a review of age discrimination in health and social care to try and uncover where ageism exists in Northern Ireland in health and social care. We are very strong. We have said we believe there's institutionalised ageism in health and social care, and for a lot of older people, it is a matter of life or death. So, again, I think it's a dialogue.
Thank you both very much.
Thank you.
I'm going to finish with just one final quick question. The first one, picked up in your evidence that you'd said that one of the issues that has come through your information and other services is actually about transport home when somebody is leaving the emergency department. And I wondered if you have any particular recommendations or suggestions about how that issue is dealt with. And my second question is, one choice for each of you, if there were one thing that you think could and should be done that would have an impact on emergency departments, what would it be and why? But if you address first of all just any suggestions about transport home.
The first one on the issue of transport, for us it seems to happen in the middle of the nights or at weekends. There is some block in the system that allows older people, and these are older people with a condition and also with dementia, to be taken home in the middle of the night without someone with them. And I think that practice should just stop, particularly if that person has dementia. And I know, let me say, that we believe that that's because of to free a bed, let's put the person back into. And in the case of us, this example was Meadowbank, that person was brought back to us, but not even in an ambulance, but by a taxi, with no support and no one with that individual. And we think that that's bad practice, and there should be some quality statements around emergency departments to say what can't happen. And that's one of them for us in terms of that transport issue. The second question, Chair, you asked, what we would change or what we would see as something we would change. I would certainly look at the triage system. If you go into the emergency departments, if someone comes in with dementia, the needs are such that sitting in 12 hours is not conducive to either them and intolerable for their carer. There should be part of that triage system that pinpoints person with dementia, this is a system of how we treat that person. Works a wee bit when you go up into the wards, there's a butterfly system. That should be down on the emergency departments to make sure that that stress and anxiety and the upset that it will cause other other patients, if the person, because of their dementia, can't lie on a trolley, wants to get up continually, needs reassurance continually, that obviously has an impact on those patients around them, and I think that could be resolved very easily by putting that system in place.
One thing for me, I suppose, would be somewhere else to go other than A and E. I think we have no, we are out of hours service in Northern Ireland is very ill designed. It's not very well. Nobody knows if we have it. People don't know if it's in their area. You ring this number, it could be 4 or 5 hours. If you're a carer at home and somebody that you're looking after is breathing, is having acid breathing difficulties, you're just going to phone ASI 999. But if there was confidence that there was a team that could come out to your house within the hour or things like that, just somewhere else to go other than A&E, because A&E, I mean, if you're ill and you need to go to A&E, that's fine. But for an awful lot of people, a lot of the issues that they deal with could be dealt with within their own homes. So just somewhere else to go, I suppose.
Okay, thank you, both of you. An offer we've made to everybody who's given evidence. You already have given us written evidence, but if there's any additional material that you'd want to provide for us, that would be very welcome. Is there any final word you'd like to make before we finish this session?
No, just to thank you for the opportunity to come along and contribute and to just share some of the experiences of our client group.
No. Well, thank you. It's been really, really helpful.
Thank you very much.
Thank you.